All right. So good morning, and thank you for having me for today. It's a privilege for me to be with you today, this afternoon. So thank you for having me as your lecturer. Well, I just want to introduce myself briefly. Okay, so this is me. My name is Miguel, and in 2013, I became a registered nutritionist dietitian. I worked as a nutrition coach for 1 year, and then in 2013, I decided to go into medical school. Fortunately, in 2019, I became a licensed MD. Okay, and then currently, when the pandemic hit, I decided to work in public health so I can help and play my role in helping stop the COVID-19 pandemic. Pero for today, ayoko muna pag-usapan yung COVID-19 as a pandemic, but I'm going to talk about another pandemic, and that is obesity. I think obesity is a global pandemic as well, and just to prove my case, I made a table, and it says here na COVID-19 cases worldwide is about 112 million and counting. And out of that, yung deaths niyan is about 2.5 million in total. As compared to obesity, 1.9 billion ang overweight and obese as of now. And out of the 1.9 billion, 650 million dyan ay obese. Okay? And deaths from that is about 2.8 million per year and counting. So I think overweight and obesity, it's also a pandemic, it's happening worldwide, and I think it's as relevant as COVID. Okay? And speaking of relevance, did you know that according to the WHO, sa mga Filipinos, 3 out of 10 Filipinos are overweight or obese. Okay? So 30%. Okay? And actually, I have a lot of family and friends that are part of this 30%. You may be part of the 30%, but that's okay because this is something very personal for me because I was one of the 30% as well. Okay, around 2008, ito ako, 2008. So I weighed over 200 pounds. I had a lot of health issues. I did a lot of trial and error, yo-yo diet, starvation diet, fad diets. I tried it all. I had to spend the last 13 years studying, applying yung mga principles of nutrition, exercise, physiology, health, and fitness para lang to achieve a healthier weight, achieve a healthier lifestyle and all that. And ito yung pag-usapan natin this evening. Lahat ng tutunan ko in 13 years, I'll try to give it all to you in one lecture. Okay? And I have specific objectives for you. So first of all, I will just give you digested and integrated information. Okay? Just everything you need to know. Okay? Digested, concise. I'll try to be as clear as possible. And I'll try to bridge the knowledge you have through clinical and real-life applications. Okay? Basically, wala na tayong pag-uusapan na hindi nyo pa alam. Basically, lahat ng to, alam nyo na to, napag-aralan nyo na to, review na lang to. But maybe ang ambag ko lang for tonight is I'll help you connect the dots better. And of course, naging med student rin ako before. Alam ko mahirap yung mga exams. So I'll help you score points on the exams. Okay, I included mga highly tested board topics, mga exams and all that. So I'll try to correlate everything for you. Okay? So okay ba yun sa inyo? So if okay yun sa inyo, react or something. Just show me that you want that or something. Okay, thank you. Thank you. All right, so without further ado, let's start. Okay, so I'm going to do an integrated lecture. I entitled it Fat Facts. Okay, so in topic outline natin for today is first we're going to start with structure. Okay, basically review of dietary fats, biochemical structure, and all that. And then pag naintindihan na natin yung structure niyan, we're going to talk about function. Basically, it's a review of lipid metabolism. Kaka-exam nyo lang daw on this topic kanina. So I think it's fresh. I think it's going to be refreshing and review na lang talaga. And then we're going to integrate along the way. Okay, so I'm going to give you clinical correlates, nothing correlated to topic, and yung mga highly tested and very useful na mga information that I know as of now in my stage of training. And then at the end, we're going to do practical applications. I'm going to try to show you how to apply everything that we discussed so far into actual nutrition, diet, and all that. Okay, so let's start with structure. Start with that then. So first, we're going to discuss about triglycerides and then fatty acids, classification, chain lengths, and then according to saturation, examples, and then briefly about essential fatty acids, and then cholesterol, and then we're going to end with lipoproteins and some correlations. Okay, so let's start. So when we talk about dietary fats, we're talking about triglycerides. Lahat ng kinakain natin na taba, we eat it in a form of triglycerides. Okay, yung triglycerides, it's made from 1 molecule of glycerol and 3 fatty acids. Okay, alam natin to from biochem. Another thing na kailangan mo important na the main storage form of fats in our bodies are in the form of triglycerides. Yung laman ng mga adipose tissue, triglycerides yun. Okay? And sabi natin, may 3 fatty acids ng triglycerides. Okay? So yung fatty acids na yan, merong classifications. Okay? Merong classification according to chain length. So may short chain fatty acid, less than 8 carbons. May medium chain fatty acids, 8 to 12 carbons. May long chain fatty acids, greater than 13 carbons. Okay? Examples yan for short chain, you don't really eat the short chains. Kasi yung short chains, ginagawa yan sa colon mo endogenously using your gut microflora, gut bacteria. Okay? Medium chain, very, very popular in the market because konti lang sila. Okay? Very good example of that is coconut oil, extra virgin coconut oil. So medium chain fatty acids yan. And then all the rest, you can bet long chain yan. Yung mga normal fats, oils na kinakain natin, usually long chain yan. Okay? So yan. So tapos na tayo sa chain length. Meron namang isa pang classification according to saturation. May unsaturated fats, may saturated fats, may trans fat. Pag sinabi mong unsaturated fats, ibig sabihin lang yan, may double bond. Pag sinabi mong saturated fats, walang double bond yung mga fatty acids. Okay? Under unsaturated fats, may monounsaturated, may polyunsaturated. Under polyunsaturated, nandiyan yung mga essential fatty acids, which we were going to discuss in the next slide. So first, let's discuss about the examples. So let's start with unsaturated fats. Under monounsaturated fat, ang pinakamagandang example niyan is olive oil. Olive oil and nuts and avocado. Okay, for polyunsaturated fats, may corn oil, soybean oil, sunflower oil, and of course, very important, mga fatty fishes like salmon, sardines. Okay, essential fatty acids. Next, saturated fats. Basically, mga saturated fats galing sa taba ng hayop, poultry, butter, milk, full cream dairy, steak,
saturated fat yan. Meron din mga vegetable fats na saturated. Example, discuss kanina, coconut oil. So yung coconut oil, although medium chain fatty acid siya by chain length, saturated fat siya by saturation. Okay, take note of that, very important. And then next, pinakahuli, trans fat, pinakamasama sa lahat, yung mga fats na to, medyo synthesize na to. They undergo a process of hydrogenation, nagiging trans conformation sila, yung biochemical structure na, and they cause a lot of havoc. Ang trans fat nakikita mostly sa mga junk food, fast food, and all that. Okay? So bakit important malaman yung classification ng fatty acids according to saturation? Because we have a concept of good and bad cholesterol. LDL is your bad cholesterol, HDL is your good cholesterol. Okay? So trans fat muna tayo, bakit may X dun sa bakit mas kumain trans fat? Because trans fat, they increase na nga your bad cholesterol, pinapababa pa niya yung good cholesterol mo. So double whammy, it's so bad. Okay, you seldom see that already in the market kasi alam nila it's so bad. Kaya in-advertise nila lagi, no trans fat, right? Okay. Saturated fat, bakit may X pa rin? Limit, limit. Hindi mo naman kailangan tanggalin ultra upper limit mo. Bakit? Kasi although increase niya yung good cholesterol, increase niya yung bad cholesterol mo. So you have to limit that. You have to eat it in moderation. Ang gusto mo talagang majority ng fat source mo is from the unsaturated fats. Why? Because hindi lang yan i-lower yung bad cholesterol mo, ini-increase pa niya yung good cholesterol mo. Alright? So I hope that's clear. Next. Essential fatty acids, under polyunsaturated fatty acids. An example niyan, omega-3 and omega-6. Okay, bakit essential? Because our body can't make these fatty acids. Kailangan natin sila kainin through diet. Through what food? Fatty fishes, ang pinakamagandang source. My favorite, salmon. Okay, so omega-3, anti-inflammatory, and omega-6, inflammatory siya. So kailangan maganda yung balance ng dalawang yan. Kailangan mas maraming omega-3 kaysa omega-6 kasi nga omega-6 inflammatory. Okay, bakit inflammatory yung omega-6? Because it is a precursor of arachidonic acid. What is arachidonic acid? I'll bring you back to this table that we all know. As you can see here, linoleic acid, precursor siya ng arachidonic acid. Yung arachidonic acid, yan yung ginagawang leukotrienes causing asthma. Yan yung ginagawang prostaglandins, thromboxanes causing inflammation. Okay? Kaya meron tayong mga drugs, ang tawag sa mga drugs na NSAIDs, anti-inflammatory drugs, steroids, and aspirin, they work through this pathway. Ini-inhibit nila yung COX. So, hindi nakaka-produce ng anti-inflammatory from arachidonic acid. Hence, it's anti-inflammatory. Okay? So, yun ang first pharmacology correlation natin. I hope you find that informative. Okay, next, cholesterol. Okay, so cholesterol, paano siya ginagawa? Let's talk about synthesis. Paano ginagawa yung cholesterol? Okay, so basically, yung cholesterol from acetyl-CoA, di ba? Remember, glycolysis, then Krebs cycle. Acetyl-CoA, magko-combine siya sa dalawang nag-combine na acetyl-CoA. Na tawag sa kanya is aceto-acetyl-CoA. So basically, tatlong acetyl-CoA nag-combine through an enzyme called thiolase, magiging HMG-CoA. Ang enzyme na nag-combine sa tatlong acetyl-CoA to form HMG-CoA is an enzyme called HMG-CoA synthase. Bakit important? Because yan yung rate-limiting enzyme sa cholesterol synthesis. Okay? Pag na-form yung HMG-CoA sa cytosol merong enzyme sa cytosol meron HMG-CoA reductase. Yung HMG-CoA reductase, kino-convert yung HMG-CoA sa mevalonate, which is mag-undergo ng series of reaction to become cholesterol. Meron tayong drug, they're called statins. They inhibit HMG-CoA reductase, hence lowering your cholesterol. Ang tira ng mga statins is through the cholesterol synthesis. Okay? And bakit natin kailangan pag-usapan ng cholesterol? Kasi it's a part of our cell membrane. We're made of cells. Lahat ng cells may cell membrane. So part siya ng cell membrane. Ang tanong, majority ba siya ng cell membrane? The answer is no. Small part lang siya. Majority ng cell membrane, they're made of phospholipids. What are phospholipids? So phospholipids, sabi natin, di ba, triglycerides is glycerol plus 3 fatty acids. Bawasan mo ng isang fatty acid yung triglyceride, magiging triacylglycerol, dagdagan mo ng phosphate group, phospholipid yun. Sila yung nagpo-form mostly of your phospholipid bilayer. Ganito yung itsura nila. Okay? So, bakit bilayer? Kasi sa taas na portion, sa labas, hydrophilic, water-loving. Bakit? Anong molecule yun? Yung red circle na yan. Glycerol yan. So, glycerol is water-loving. And then yung tail, hydrophobic. Bakit hydrophobic? Kasi fatty acids yung mga yan. Pag may kink, may double bond, ano yan? Unsaturated yan. Pag wala, straight, saturated yan. So, yan yung nag-form ng phospholipid bilayer. I hope this is clear. Okay? On top of that, in times of cellular stress, na-stress yung katawan mo, na-stress yung cells mo, mag-breakdown yung mga phospholipids na yan. And they form arachidonic acid. Okay? To form inflammatory molecules like what? Prostaglandins, leukotrienes. Okay? Anong enzyme? Phospholipase A2. Meron tayong drugs, steroids. They inhibit phospholipase A2. Kaya yung mga steroids, very potent anti-inflammatory. Because yung tira nila is from there, from your cell membrane breakdown. Yeah, very potent anti-inflammatory pero maraming side effects. Okay? So yan yung correlation niya. Okay, speaking of steroids, meron tayong endogenous steroids, okay? And they're made from, guess what? Cholesterol. Ano yung tatlong endogenous na steroid hormones na yan na very important for life? Aldosterone, cortisol, and testosterone. Okay? They're all made from cholesterol. Paano ginagawa from cholesterol? You have to use enzymes. Like what enzymes? 21-hydroxylase, 17-alpha-hydroxylase, and 11-beta-hydroxylase. Pag nagkulang ka sa mga enzymes na yan, magkakaroon ka ng sakit. Usually mga pedya kasi congenital to. Pagkapanganak mo, wala ka ng enzyme, malas ka. Okay? Makikita sa newborn screening. So, magkakaroon ka ng congenital adrenal hyperplasia. Okay? Basically, CAH, congenital adrenal hyperplasia, kulang ka sa enzymes. Okay? Pag nagkulang ka sa 21-hydroxylase, automatic hypotensive yung baby na yun. Pag nagkulang ka sa 11-beta-hydroxylase, automatic yung clinical sign ng batang yun, mataas ang testosterone. Kung babae siya, virilized siya. May clitoromegaly siya. Okay? Pag lalaki siya, mag-undergo siya ng puberty ng maaga. Okay? Pag 17-alpha-hydroxylase yung kulang sa'yo, wala yung mga testosterone. So, lahat yan, itsurang babae. Kahit lalaki, naging itsurang babae. Okay? So, this is a highly, highly tested concept sa boards, sa exams. So, take note of this slide. Very high yield yung slide na to. Pag maalala mo to exam, madali na to sa'yo. Pero pag di mo to maalala, mahirapan kang malilito ka. Okay? Next, how do you study this? Congenital adrenal hyperplasia. Okay? Nasa pangalan yung sagot. Okay? Mga batang to, pag pinanganak, yung adrenal glands nila hyperplastic. Bakit hyperplastic? Kasi kahit isa lang yung kulang dyan, kahit ano dyan ang magkulang, 21 man, 11, 17, ang ending niyan, low cortisol. Wala silang cortisol. So kung walang cortisol, walang negative feedback sa hypothalamus and the pituitary gland. Continuous silang mag-release sila ng ACTH. ACTH will stimulate the adrenal gland. Kaya hyperplastic sila. Okay? Ngayon, which part of the adrenal gland ang sinistimulate? Okay? Ang sagot is the cortex. Okay? Very important to know na, anatomy na tayo. So, very important to know na sa cortex ng adrenal gland, may 3 layers, glomerulosa, fasciculata, and reticularis. Ano yung ginagawa sa zona glomerulosa? Aldosterone, for salt. Ano yung ginagawa sa fasciculata? Cortisol, for sugar. Ano yung ginagawa sa reticularis? Testosterone, for sex. So, very important, tandaan nyo sa slide na to, high yield mnemonic, GFR, salt, sugar, sex. Okay? So again, itong slide na to, very high yield. Balikan nyo to sa board exam. Okay? So move on na tayo. Next, lahat ng napag-usapan natin so far, lahat ng yan mag-culminate into lipoproteins. Lahat ng taba, cholesterol, and all that, they travel through our body through lipoproteins. Maraming kinds of lipoproteins. May chylomicrons, may VLDL, IDL, LDL, HDL. Paano mo maalala yan? Kailangan mo lang maalala na pag chylomicron pinag-usapan, siya yung pinaka-triglyceride rich. Okay? And once it travels to our bloodstream, mayroong mga enzymes, lipoprotein lipase, binabawasan nila lang taba yung chylomicron para maging VLDL. Hanggang sa maging LDL na lang siya, cholesterol na lang natira. So, yung LDL is yung pinaka-cholesterol-rich na lipoprotein. Kaya siya yung tawag na bad pag sobra. Pero essential din siya on a normal amount. Pero pag bad siya pag sumusobra. Okay? And then, buti na lang may HDL, good cholesterol, kasi lahat ng ginagawa niya ng sobrang LDL na bad, nire-reverse ni HDL. Kaya siya good cholesterol. Okay? So, yun na yun. Basically, that's it. So, correlate na tayo clinically through the lipid profile test. Yan yung mga discuss ko kanina ng structure. Yan yung in-order sa lipid profile test. Okay? So, dahil pinag-aaralan natin yan, masasagot mo na yung tanong na pinaka-basic na fasting ba ang lipid profile test? Okay? Fasting ba? The answer is yes. Kasi, sabi natin, lahat ng kainin mo in the form of triglycerides. So, pag hindi ka nag-fasting, nagpakuha ka ng lipid profile test, titingnan yung triglycerides mo will be falsely high. Bakit masama yun? Kasi, lahat ng yan, nakikita ng labs, mini-measure ng labs directly, except LDL. The bad cholesterol, pinaka-important. Lahat ng yan, mini-measure directly except LDL. Kasi yung LDL, kino-compute siya. Ito yung formula niya, Friedwald equation. Kino-compute siya from the other values. And subtraction siya, total cholesterol minus HDL minus triglycerides over 5. So kung di ka nag-fasting, pinakuha mo yung pasyente mo ng lipid profile test, di siya nag-fasting, yung triglycerides niya falsely high. So nasa numerator yung triglycerides, subtraction pa. Ano mangyari sa LDL? It will be falsely low. You don't want to misinterpret the LDL kasi it can mean bibigyan mo siya ng drugs or hindi. Kaya kailangan fasting yung lipid profile test. Okay? So sa exam, papakompute nila kayo for sure. Pero buti na lang, sa real practice, may mga labs like high precision, hindi mo na kailangan mag-compute. Okay? So tapos sa diet structure, we already correlated through the lipid profile. Okay? So kaya natin pag-usapan yung function. Okay? So sabi, alam ko nag-exam kayo sa lipid metab, so kind of review na lang to and I'll try to synthesize the topic. Okay? So let's start first with transport. Okay? So sabi natin, okay, pag kumain tayo ng dietary fats in the form of triglycerides, they get packaged into chylomicrons. Okay? Pag yung chylomicrons nasa bloodstream na, may enzyme, LPL, lipoprotein lipase, babawasan niya ng triglycerides yung chylomicron. Saan mapupunta yung triglycerides? Pwede ma-store in your adipose tissue. Okay? Pag naubos na yung triglycerides ng chylomicron, magiging remnant na lang siya. Yung remnant na yan, pupunta sa liver, marirecycle ng liver, magiging VLDL. Okay? VLDL, galing sa liver yan. Chylomicron, galing yan sa triglycerides na kinain mo. So VLDL, mag-act pa rin sa kanya si LPL, babawasan siya ng triglycerides hanggang sa cholesterol na matira, LDL. Yung LDL na yan, masama pag sobra. Kasi pwede siyang mag-deposit sa other cells mo. Pinaka-favorite niya sa blood vessels mo, causing atherosclerosis. Pero in normal amounts, and normally, physiologically, saan siya pupunta? Given na cholesterol-rich siya. The answer is adrenal glands. Why? Kasi kailangan mo gumawa ng steroid hormones. Saan galing cholesterol? Kay LDL. So, kailangan pa rin siya. He's not that bad at all. He's not that bad anyway. Alright? So, pag sobra lang siya bad. Okay? Remember that. So, pag nasobrahan si LDL ng kasamaan, okay, buti na lang may HDL, good cholesterol, i-reverse niya lahat ng mga ginawa ni LDL. Reverse cholesterol transport yung tawag. Babalik niya sa liver. Okay? Next. So, tapos tayo sa transport, alam na natin. Ngayon, let's talk about storage. Okay? Yung storage, lipid storage, nangyayari lang yan in a high insulin and fed state. Kailangan mataas yung insulin mo. Okay? So, ulitin natin. Chylomicron from diet, VLDL from liver, acted upon LPL, ang ending, fatty acids. Fatty acids, substrates for triglycerides, papasok sa adipose tissue freely. Bakit? Kasi fatty acids siya. So, hindi siya mahirapang pumasok. Phospholipid bilayer, fatty acids naman siya. Hindi siya mahirapan. Okay? And, mangyayari lang yan kung may insulin. Why? Because insulin, magbabind, pag mataas yung insulin mo, magbabind yan sa receptor niya sa adipose tissue, isi-stimulate ng insulin yung release ng LPL and yung action ng LPL, i-activate yung LPL. Okay? Number 2, activate niya yung GLUT4 receptor para yung glucose makapasok ng adipose tissue rin. For what? For glycerol. So may fatty acids ka na, may glucose ka na, and then inside, gawas ng glycerol, they form triglycerides inside. Okay? Ang masama sa lipid storage nito, walang limits to. Basta all the conditions are present, tuloy-tuloy ka lang mag-store ng fat. Kaya nagiging obese, overweight yung mga tao. Okay? So tapos tayo storage. Next tayo. lipolysis. Ito yung pinaka-gusto natin lahat ng tao gusto to burn fat. Lipolysis is basically burning fat. How do you do this? You have to induce a low insulin and fasting state para magawa mo to in your system. Kasi pag mababa yung insulin mo in a fasting state, ang meron ka is counter-regulatory hormones such as epinephrine, glucagon, cortisol, and growth hormone. Okay? For epinephrine and glucagon, they will bind to your adipose tissue, may receptor sila dyan, and then they will activate adenyl cyclase, and then adenyl cyclase will convert niya ATP sa CAMP. CAMP activate niya protein kinase A, kinase yan, so they add phosphate, nata-phosphorylate sila, so they phosphorylate hormone-sensitive lipase. Pag na-phosphorylate yan, hormone-sensitive lipase, ma-activate siya, and then it will burn the fat. Ito na yung ultimate fat burner, hormone-sensitive lipase yun. Burn niya, titirahin niya yung triglycerides inside your adipose tissue, gagawin niyang glycerol and fatty acids. Okay? And dahil ito yung dito interested most of the people, or at least the clients I know, let's discuss in more detail. Okay, I'll walk you through this. So, within natin. So, epinephrine, catecholamines, and glucagon will bind to the receptors. They will activate adenyl cyclase. Adenyl cyclase, ATP, magiging CAMP. CAMP activate niya PKA. PKA, phosphorylate niya si hormone-sensitive lipase. Hormone-sensitive lipase break down yung triglycerides to form glycerol and fatty acids going to the blood. Okay, that's how fat burn lipolysis happens, only in a low insulin and fasting state. Let's take a look a little bit on the right. Paano kung may insulin? Ano mangyayari? Pag may insulin, magbabind siya sa receptor niya sa adipose tissue, i-stimulate niya si LPL at si GLUT4, makakapasok yung mga fatty acids, and at the same time, it will stimulate the enzyme that degrades CAMP, phosphodiesterase, PDE. So, mawawala ka ng CAMP. Pag nawala CAMP, wala ng PKA. Pag wala si PKA, hindi niya ma-activate si hormone-sensitive lipase, hindi ka makakapag-fat breakdown. Kaya, insulin, hindi okay yan. Pag gusto mo lipolysis. Let's take a look here, caffeine. Si caffeine, it does the exact opposite. Inhibit niya yung degradation ng CAMP para mag-proceed yung red pathway, lipolysis. Okay? Kaya caffeine, kaya pagka nagtitake ka ng fat burners, you like fat burners, maraming caffeine yan. This is one of the actions of caffeine. Okay? Next, sa taas, kung hindi ka uminom. Okay? ETOH, alcohol. I-activate rin yung PDE. So it will increase the degradation of CAMP. So the red pathway will not proceed. Okay? Pag green pathway na proceed, anong ending yan? Lipid storage. Ayaw mo yan. Okay? Gusto mo, lipolysis, di ba? Okay. Dahil gusto mo ng lipolysis, gusto mo ng fat burn, gusto mo to burn fat, let's take a look at what happens sa glycerol and fatty acid pag nag-burn ka ng fat. Okay? Kasi first part pa lang to. This is what happens inside the adipose tissue. Okay? So, nalulusaw pa lang yung taba dito. Ano na mangyari sa glycerol and fatty acids? Let's take a closer look at that. Let's start with glycerol. So, yung glycerol, in a low insulin and fasting state, yung glycerol lalabas siya ng adipose tissue, punta siya sa bloodstream, diretso siya sa liver. And inside the liver, may enzyme, glycerol kinase, phosphorylate yung glycerol forming G3P. Yung G3P pwede ma-convert sa DHAP, dihydroxyacetone phosphate, and then it will proceed the reaction forming glucose for gluconeogenesis, only in a fasting state, in low insulin state. Okay? Correlate tayo. Bakit important mag-exercise? Kasi pag nag-exercise ka, pinapataas mo yung epinephrine mo and cortisol. Okay? Kung ano yung mga yan? Counter-regulatory hormones. Saan galing yung epinephrine? Adrenal, medulla, catecholamines. Diba? So, epinephrine, cortisol will bind to the receptors, stimulate yung adenyl cyclase, CAMP, PKA, hormone-sensitive lipase, ending glycerol lipolysis. And then, gluconeogenesis will take place. On top of that, yung skeletal muscles mo and your liver, merong yung mga glycogen. So, binoburn din yan when you exercise, forming glucose. This process is called glycogenolysis. Okay? So, alam na natin nangyari paano nakagawa ng glucose from these two activities. Ngayon, what happens to the fatty acids? Okay? Ang sagot, yung fatty acid na yan, galing sa lipolysis, galing from adipose tissue, magiging acetyl-CoA yan. Okay? Saan yan magiging acetyl-CoA? Sa liver mitochondria through a process called beta-oxidation. Only happens in the liver, not only, but mainly occurs at the liver mitochondria. Okay? Oh, take note. Exercise, okay. Bakit? It also increases HDL through a variety of reasons. Okay? So take note of that. So, okay, beta-oxidation. Paano na magiging acetyl-CoA yung fatty acid? Okay. So, mostly ng diet natin, long-chain fatty acids. Okay. Pagkagaling sa adipose, na-breakdown siya ng hormone-sensitive lipase, lalabas siya ng bloodstream, punta siya sa liver. Pag nasa liver na siya, hepatocyte, cytosol ng hepatocyte, it will approach the mitochondria, pero hindi siya makakapasok. Okay. Kailangan mag-up on sa kanya si acyl-CoA synthetase para ma-activate niya si long-chain fatty acid. Kasi take note, acyl-CoA lang ang pwede mag-undergo ng beta-oxidation. Okay? So, pag nag-up sa kanya si LACS or acyl-CoA synthetase, naging acyl-CoA na siya. Hindi pa rin makakapasok sa acyl-CoA. Kailangan niya ng isang enzyme, very important enzyme. It's called CPT, Carnitine Palmitil Transferase. It's the rate-limiting enzyme for beta-oxidation. Kailangan niya dagdagan si acyl-CoA ng carnitine, making acyl-carnitine. Acyl-carnitine, makakapasok na siya sa liver mitochondria, which specifically where in the mitochondrial matrix, sa inner mitochondrial membrane. Okay? And then sa acyl-carnitine, sabi natin, acyl-CoA lang pwede mag-undergo ng beta-oxidation. So, kailangan i-convert ulit siya sa acyl-CoA. Then, pag acyl-CoA na siya, pwede siya mag-undergo. So, bakit important ang medium-chain fatty acids? Bakit sikat na sikat ang extra virgin coconut oil? Bakit pinagkakaguluhan siya? Kasi medium-chain fatty acids, they can bypass the whole carnitine system. Pasok sila agad. Diretso beta-oxidation. Ganun kadali. Kaya sabi nila, it's good. Okay? Alright. So, yun. Okay, yun. Okay, another example of a medium-chain fatty acid source, breast milk. Kaya breast milk is best for babies. Okay, so let's talk about beta oxidation. Okay, sa mitochondria, review lang ulit, but in more detail. So, low insulin fasting state, the fatty acids from your adipose tissue will undergo beta oxidation sa liver mitochondria, inner mitochondrial matrix. Pero bago mangyari yun, dadaan siya sa Carnitine system. Sa Carnitine system, pag fatty acyl-CoA na siya, it can undergo beta oxidation. Ano ang end products niyan? Acetyl-CoA and two high energy molecules, NADH and FADH2. Yung dalawang yan will go to your electron transport chain, creating a lot of ATP for you. Kaya fats, or burning fat, or beta oxidation, it's a very fuel efficient way of burning and creating ATP for energy. Alright? And yung acetyl-CoA na yan, marami siyang pwede mangyari dyan. It can enter the Krebs cycle or become ketones, which we're going to talk about later. Okay, so I hope that's clear. Okay. Next, pag hindi pa, okay, may tanong kasi. Pag hindi ako mahilig kumain ng fats, tataba ba ako? Ang sagot, oo. Kasi merong tinatawag na lipogenesis and synthesis. Paano nangyayari yun? Let's talk about it. Inside the cytosol, outside the mitochondria, yung mga acetyl-CoA na yan, in a high insulin and fed state, maraming insulin, may isang enzyme na very important, ACC, acetyl-CoA carboxylase. Ang ginagawa, pag may insulin sa cytosol or sa system mo, ang ginagawa ni insulin dyan, dinidephosphorylate niya yung ACC. And ACC, when it becomes dephosphorylated, it becomes activated. Pag na-activate si ACC, yung acetyl-CoA mo in the cytosol, magpo-form siya ng malonyl-CoA. Malonyl-CoA, this is the key. Bakit? Kasi malonyl-CoA, inhibit niya yung CPT1. Ano yung CPT1? Carnitine palmitoyltransferase 1, the rate-limiting enzyme for beta oxidation. So kung in-inhibit mo yan, hindi magti-take place yung beta oxidation. No beta oxidation, hindi ka mag-burn ng fat. Okay? So yung malonyl-CoA pwedeng gamitin na substrate for lipogenesis. Tataba ka. Okay? Okay. So ayaw mo yan. Ayaw mo maging high insulin and fed state. Gusto mo fasting. Okay? Kasi pag fasting, glucagon and epinephrine meron. Anong ginagawa nila? Diba? Adenyl cyclase, CAMP, PKA, phosphorylation. So if phosphorylate, they keep the ACC phosphorylated. So pag phosphorylated sa ACC, inactivated siya. Convert ba niya si acetyl-CoA sa cytosol to malonyl-CoA? Hindi. So lipogenesis won't take place. So beta oxidation will take place. Gusto mo yan. Gusto mo yan. Fat burn. Okay? Mind you, sa mga nag-intermittent fasting, yan yung reason why you do intermittent fasting. You want to keep your system doing beta oxidation all the time by keeping your insulin very low. Okay? And very important, take note, sa mga nutrition boards, ACC, this is the rate-limiting enzyme and the main regulatory enzyme for this whole lipogenesis process. Okay? And this happens in the cytosol. Okay? Let's talk about what happened in the mitochondria. Mainly, paano nakalabas si acetyl-CoA sa cytosol? Hindi yan pwedeng makalabas sa cytosol. Kasi acetyl-CoA can only be inside the mitochondria. It can go out. So ano nangyari? Okay, I'll bring it to the table. So in a high insulin and fed state, inside the mitochondria, kung high insulin and fed state ka, yung oxaloacetate mo, sobrang taas, magko-combine siya with acetyl-CoA inside the mitochondria forming citrate, Krebs cycle. Citrate lang ang pwedeng makalabas ng cytosol. So lalabas si citrate ng cytosol wherein it is reconverted to acetyl-CoA. What enzyme? ACC. Kasi mataas yung insulin, dephosphorylated yan, activated siya. And nutrition correlate, may isang cofactor na kailangan for this reaction to proceed, and that's biotin. Lahat ng carboxylase reactions kailangan ng biotin. Okay? That's why biotin is very important as well. So, yung acetyl-CoA mo with ACC and biotin magiging malonyl-CoA. Malonyl-CoA, inhibit niya yung CPT1, so walang beta oxidation. And it can be used to form fatty acids, a process called lipogenesis. Okay, so I hope that's clear. Next. So, okay, ulitin lang natin. High insulin and fed state, sa mitochondria, acetyl-CoA, magko-combine sa oxaloacetate, maging citrate lalabas maging cholesterol fatty acids. So, a series of reaction na discuss natin sa previous slide. Okay, so may fatty acids ka na for storage. Saan galing yung glycerol? Okay, tanong, saan galing yung glycerol? Ang sagot dyan, pinaka-potent na pinanggagalingan ng glycerol, fructose. Bakit? Fructose can be easily converted to glycerol through DHAP and all that. So, kompleto na triglycerides sa taba ka ng unlimited. Lipogenesis. Okay? So why? Let's talk about fructose metabolism for a little bit. So fructose in a high insulin, okay, fructose induces also a high insulin and fed state. Okay? So kung fructose, convert siya sa GA, DHAP, and GA3P. GA3P will proceed to the Krebs cycle, hindi pwede kang magkaroon ng fatty acids. And then yung DHAP, GA, convert sila sa glycerol 3P. So meron ka ng glycerol. So may fatty acids ka na, may glycerol ka pa. So may triglycerides ka na. Just from fructose. Okay? That's why fructose, kung ayaw mo magpataba, bawasan mo yung fructose mo. Okay? Kasi fructose can easily provide all the substrates for fat synthesis. Hindi siya fat source, it's a carbohydrate. Pero it easily provides all the substrates. And kung tingin mo yung fructose galing lang sa fruits, nakamali ka. Because fructose, meron yan sa lahat ng snacks and beverages that we all like. Okay? And it comes in the form of high fructose corn syrup, pinakamasamang type ng fructose. Bakit yan meron sa mga snacks? Kasi favorite yan ng mga food manufacturers mo. Mga snack, gumagawa ng mga snacks, they make profit out of you. Why? Because high fructose corn syrup, they are tasty, they make your food taste well, they make your drinks taste well, na-addict ka, it mixes very well, nakagawa sila ng maraming products, and it's very cheap. They can make a lot of profits from it. Okay? So, very common yung fructose yan. Halos lahat meron yan. So, challenge ko pa kayo. Punta kayo sa grocery, pagka tapos na yung lockdown, makaka-grocery na kayo. So, pupunta kayo sa snacks section, wala kang makikita doon na walang fructose. Okay? Kung meron ka makitang snack na walang high fructose corn syrup, meron yung sugar. Sugar is sucrose. Sucrose, gawa yan sa glucose and fructose. So, may fructose pa rin. Okay? So, yan, fructose, it's not really that good for you. Why? Because pag nasobrahan ka sa fructose, it can easily enter your liver. Bakit? Yung liver, meron siyang receptor specifically for fructose. It's called GLUT2. So kahit hindi ka uminom ng alak, pwede ka magkasakit sa atay. It's called non-alcoholic fatty liver disease. Common culprit, fructose. Okay? So, importante alam natin yan. Okay, so next, pinaka-inaabangan, ketogenesis. Paano nangyayari yung ketogenesis? Ketogenesis, mind you, only happens in a low insulin and fasting state. Bakit ko ito di-discuss? Kasi very popular ang ketogenic diet. Okay, a lot of people are into ketogenic diet. Mind you, ketogenesis only happens in a low insulin and fasting state. So ulitin natin yung process para mas clear. So, inside the liver mitochondria, yung fatty acids na meron ka, ma-activate to acyl-CoA. Acyl-CoA will undergo beta oxidation forming acetyl-CoA. Tatlong acetyl-CoA, magko-combine. Anong product niya? HMG-CoA. Pero, wala na tayo sa cytosol. Yung cholesterol, nagagawa sa HMG-CoA sa cytosol. Wala na tayo sa cytosol. Nasa liver mitochondria na tayo. So, sa liver mitochondria, specifically, may specific enzyme sa liver mitochondria. It's called HMG-CoA lyase. Kaya niyang gawin yung HMG-CoA into ketones like acetoacetate and hydroxybutyrate, your ketones. Okay? Specifically in the liver. Sa liver lang nakakagawa ng ketones. Alright? And it's very important to take a look at this diagram. Yung acetyl-CoA mo, hindi mo pinaproceed ng Krebs cycle. Okay? Kailangan ma-push mo siya into ketogenesis bago pa siya mag-proceed ng Krebs cycle. Okay? Correlate tayo. Bakit? Kasi, paano mo gagawin yan? Kasi, kailangan mong i-deplete yung oxaloacetate mo. Okay? Yan yung oxaloacetate, very important, kasi yun yung magdidikta kung yung acetyl-CoA mo mag-proceed sa Krebs cycle or to ketogenesis. So, ang kailangan mong gawin, kung gusto mo mag-keto diet, gusto mo to be in ketosis, kailangan i-deplete mo yung oxaloacetate mo. Paano mo i-deplete yung oxaloacetate mo? Kailangan i-push mo siya towards gluconeogenesis. Papalabasin mo siya ng mitochondria to PEP and then upwards to the gluconeogenesis pathway. Kasi kung hindi mo i-deplete yung oxaloacetate mo, acetyl-CoA from your fatty beta oxidation, magko-combine sa oxaloacetate inside the mitochondria, they will form citrate. Citrate lalabas, become acetyl-CoA outside, ACC, biotin, malonyl-CoA, fatty acids, lipogenesis, tataba ka. Imbis na, kung naka-keto diet ka, imbis na tinuturuan mo yung body mo, pinupush mo yung body mo into ketogenesis, dahil hindi mo dinipit yung oxaloacetate, nagkamali ka. Okay? Pinush mo yung body mo into lipogenesis, tataba ka. Keto diet won't work for you. Yan yung nangyari sa friend mo na sabi niya nagki-keto diet siya pero wala nangyari sa kanya or tumaba siya. Yan yung nangyari sa kanya. Pwede mo sabihin sa kanya, bro, hindi mo dinipit yung oxaloacetate. Kailangan natin i-deplete yung oxaloacetate. Paano natin i-deplete yun? Kailangan low carb ka. You have to be in a low insulin state. And then high fat yung diet mo para marami kang fatty acid beta oxidation, para marami kang acetyl-CoA to push into ketogenesis. Okay? So I hope that's clear. I hope that's helpful. Next, ano mangyayari pag na-over ka naman ng ketones? Okay? Ano mangyayari? Okay, nangyayari yung na-overload sa ketones pag walang insulin. Ang tawag sa sakit na yan, diabetic ketoacidosis. Happens sa mga type 1 diabetics. Kasi pag wala silang insulin, mataas yung glucagon nila, epinephrine, okay, magbabind sa adipose tissue, hormone-sensitive lipase, glycerol yung ending, gluconeogenesis, tataas yung glucose. Okay, glucose, it attracts a lot of water, iihi mo lahat yan, madideplete yung volume mo, madidehydrate yung patient. On top of that, pag nangyayari yan, walang insulin, you have a lot of cellular stress, phospholipid breakdown. So marami kang arachidonic acid, inflammatory markers. So it will inflame your whole body, causing nausea, vomiting, abdominal pain. Okay? On top of that, wala kang insulin at all. Oxaloacetate mo, sobrang depleted. Lahat ng fats mo from fatty acid breakdown, dahil mataas ang glucagon, epinephrine, hormone-sensitive lipase, lahat ng yan push towards ketogenesis. So nagkakaroon ka ng ketones overload. Nagkakaroon ka ng high and iron gap metabolic acidosis because ketones are acidic. Okay? Bakit mataas yung gap? Kasi yung gap na yun, they're made of ketones. Okay? So anong gagawin mo? When you're presented with this patient, anong gagawin mo? Unang-una, syempre, kailangan mo to clinch the diagnosis. Paano mo gagawin yun? So kailangan, may knowledge ka ng, kung may labs ka, madali. Kasi pag kuha mo ng CBG, fasting blood glucose, mataas yung sugar. Okay? Hyperglycemic. Pag tingin mo sa ihi, maraming ketones. Okay? So, okay na. Pag tingin mo ng ABG, acidotic. Pag tingin mo ng electrolytes, mababa yung bicarb. So kung may labs ka, madali. Anyway, ER case naman to, emergency case to. Pero paano kung wala kang labs? Anong gagawin mo? You have to rely on your clinical skill. Kailangan may alam ka sa acid-base balance. Okay? Kailangan mo malaman na in patients with DKA, they undergo a metabolic acidosis. So kailangan mag-compensate ng lungs. Through what? Kailangan mag-induce siya ng respiratory alkalosis. Paano siya mag-induce ng respiratory alkalosis? Kailangan mag-blow off siya ng maraming CO2. So anong gagawin ng patient? Hihinga siya ng mabilis at malalim. It's a clinical finding called Kussmaul's breathing. Okay? And then paglapit mo sa kanya, huminga siya ng mabilis at malalim, nagko-Kussmaul's breathing siya. Pag amoy mo sa breath niya, fruity. Bakit? Kasi acetone yun, ketone. So, pag naamoy mo yan, very specific yan for DKA. Pwede mo na-diagnose yung patient na DKA. Okay? Pag na-diagnose mo na siya, ano kailangan mong gawin? First of all, kailangan mong gawin is give him a lot of fluids. Hydrate mo siya kasi sobrang dehydrated yung patient na to. Okay? And then, next, you give insulin, infusion IV. Okay? Meron pa mga iba, you have to take a look at the potassium and all that, pero next time na yun. Okay? Si senior intern and friendly resident ng bahala doon. Okay? Alright. Next. Okay, alcohol. Marami sa atin mahilig ng alak. Paano ito nangyayari? So, alcohol, okay, you have to take note na yung alcohol, it induces a high insulin and fed state. Okay, kasi may carbohydrate din ito and all that. And may calories to per gram. On top of that, it is metabolized as a poison by the liver. So, pinaprioritize siya over anything else pag meron kang alak in your system. Okay, so paano nangyayari yun? So, yung ethanol will be acted upon alcohol dehydrogenase. Okay, ko-convert yung alcohol sa acetaldehyde, tapos may byproduct ka na NADH. Take note of this byproduct. And then, maging acetaldehyde yan. Yung acetaldehyde will be acted upon aldehyde dehydrogenase, magiging acetate. And meron ka ulit byproduct na NADH. Take note. Okay? Ngayon, very important, correlate tayo. Okay? Yung acetaldehyde, yan yung carcinogenic, yan yung masama, yan yung nagkakos ng hangover pag nag-build up yung acetaldehyde. Okay? So, lahat naman tayo siguro nakatry na mag-minom, na hangover tayo. Bakit? Kasi nag-build up yung acetaldehyde mo in your system, nasobran yung ethanol mo. Okay? Merong drugs, they're called disulfiram, they inhibit aldehyde dehydrogenase. Okay? May mga antibiotic, they have side effects, disulfiram-like reaction, they act like disulfiram. Anong ginagawa ng disulfiram? They inhibit aldehyde dehydrogenase. So pag nangyari yan, ano mangyari? Mag-build up yung acetaldehyde mo, magkakaroon ka ng massive headache and hangover. Kaya pag nagpe-prescribe yung doctor mo ng antibiotic, sasabihin niya, uy, huwag ka uminom ng alak with this. Bakit? Kasi baka may potential disulfiram reaction. Okay? Common example ng antibiotic, pinaka-common, metronidazole. Okay? Take note that, highly tested. Okay? Pero for us Asians, including myself, hindi na natin kailangan disulfiram kasi kulang talaga tayo sa aldehyde dehydrogenase. Kaya nagkakaroon ng Asian flush kasi nag-build up yung acetaldehyde. Isang inom pa lang, mapula na, lasing na. Kasi kulang yung aldehyde dehydrogenase talaga natin. Okay? So, yan yun. Okay. On top of that, yung acetate na end product ng ethanol metabolism, they can be converted to fatty acids. So, tataba ka. Okay? And also, take note of the NADH. Bakit? Kasi yung NADH na pinataas mo through alcohol, it will, mag-snowball yan into a series of reaction causing a lot of havoc to your system. That is the main culprit kung bakit masama yung alak. Kasi pinapataas mo yung NAD. Okay? So, paano nangyari? So, okay, minom ka ng alak, ethanol, di ba? Ethanol. So, you convert the ethanol to acetaldehyde. Meron kang byproduct, NADH. Acetaldehyde mo naging acetate. Yung acetate mo, it gets converted to acetyl-CoA. Acetyl-CoA, hello, in the cytosol, merong ACC. Maraming insulin. So, dephosphorylated ACC plus biotin, convert siya to malonyl-CoA. Pag may malonyl-CoA ka, ano mangyayari? Wala nang beta-oxidation. May alak sa system, hindi ka na mag-burn ng fat. Wala nang beta-oxidation. Yung malonyl-CoA, mag-undergo to fatty acid lipogenesis in the cytosol. Okay? Glycerol, saan galing? Okay, ulitin sa kabila. Ethanol, convert sa acetaldehyde, may NADH ka. Dahil mataas yung NADH-NAD ratio mo, yung DHAP mo, you will push it towards glycerol. So may glycerol ka, may fatty acid. Okay? Mag-store ka ng fat pataba. Okay? Sa fat storage pa lang, pang pataba pa lang yan. Hindi pa dyan nagtatapos yung problema na pinapos ni high NADH and NAD ratio. Ano pa? Ito pa. Okay? Pag mataas yung NADH-NAD ratio mo, you affect the gluconeogenesis. Okay? Sobrang mag-glycolysis yung, overdrive yung glycolysis ng patient mo. It will cause severe hypoglycemia. Kaya yung mga chronic alcoholic natin, usually nawawala ng malay. Naging hypoglycemic. Okay? Next, yung pyruvate mo, napupush towards conversion to lactate. Hindi siya napuproceed sa Krebs cycle. So, nagkakaroon ka ng lactic acidosis. Okay? On top of that, sabi natin, yung fat breakdown mo decreased. Bakit? Kasi may malonyl-CoA. Diba? From acetate, acetyl-CoA, malonyl-CoA. So, wala kang fat breakdown. Increase yung fat synthesis mo. So, nagkakaroon ka ng fatty liver. So, toxic siya. Okay? So, yan. Okay. So, take note, very important. Main culprit, bakit masama ang alak sa system? Kasi pinapataas niya yung NADH-NAD ratio. Okay? Higher yun. Okay, so let's talk about alcohol even more. May two kinds of alcoholics. Merong acute alcoholic, your regular party people, usually matataba sila. Bakit? Kasi kahit mahilig sila uminom ng alak, kumakain pa rin sila, namumulutan sila. So usually mataba sila. Ang pinakaayaw natin, pinakamasama, pinaka-deadly, ay yung mga chronic alcoholic, mga na-addict na sa alak. Hindi na sila kumakain. So, ang ending nila, payat na sila. Tapos malaki na lang yung tiyan nila kasi fatty liver na. Okay? Pagka ganyan na yung pasyente mo, chronic alcoholic, you should suspect nutrient deficiencies already. So, toxic yan. Ano yung pinaka-common na nutrient deficiency na meron sa mga chronic alcoholic? Thiamine. So, pag nagkulang sila sa thiamine, a lot of biochemical reactions don't take place. So, pag hindi nag-take place yan, Krebs cycle hindi mag-take place and all that, wala kang ATP. Pag wala kang ATP, ano mangyari? Okay, affected si brain. Kasi what consumes most of your ATP is your brain. So, nasisira si brain. Pag naging chronic alcoholic ka, pag nasira yan, tuloy-tuloy, ano mangyayari sa'yo? Magkakaroon ka ng Wernicke-Korsakoff syndrome. So, chronic alcoholics, nagiging deplete sa thiamine, their brain undergoes ischemia and cell death, nagkakaroon sila ng Wernicke encephalopathy kasi yung brain na nawala ng ATP. So, may Wernicke's, nagkakaroon sila ng confused state, ophthalmoplegia, masakit mata pag ginagalaw, ataxia, wobbly. Pag nag-continue yan, chronically, nagkakaroon sila ng Korsakoff syndrome. So, wala ng memory, kung ano na sinasabi, wala sa sarili. Okay, Wernicke-Korsakoff syndrome, thiamine deficiency, chronic alcoholics. Okay, bigyan kita ng clinical correlate. Para kung nasa ER ka, nagkaroon ka ng pasyente na ganyan. Kita mo, uy, payat, passed out, loss of consciousness. Tapos, paglapit mo sa kanya, amoy alak. Okay? Ang gagawin mo? Okay? Ang gagawin mo, una, kailangan maisip mo, uy, baka chronic alcoholic to. So, hindi to kumakain, kaya nag-pass out, minom ng alak. Tapos, yung clerk mo, yung junior mo, kukunan siya ng CBG, makikita, hypoglycemic. So, dahil hypoglycemic, mag-order siya ng dextrose. Bibigyan mo ba siya ng dextrose? Para to replenish the blood sugar. Pag ginawa mo yun, pwede siya mag-Wernicke-Korsakoff sa harap mo. Bakit? Kasi, kulang na nga siya sa thiamine, kung ano pang merong thiamine na natitira sa kanya, okay, dahil binigyan mo siya ng substrate, tapos sobrang overdrive yung glycolysis ng mga chronic alcoholics, di ba? Lahat ng thiamine niya, inubos mo by giving that load of dextrose. So you don't do that. Pag may suspecha ka na chronic alcoholic, what you do in the ER na passed out, what you do is you give thiamine first by IV, and then you give the dextrose. Replenish mo muna yung thiamine. Kaya very important yung thiamine as a vitamin. Vitamin B1 for chronic alcoholics. Okay? So nutrition correlate lang yun. Next, Malapit na tayo matapos. So, clinical coordinate tayo, fatty liver. So, in a chronic high insulin state, nagkakaroon ka ng fatty liver. Kasi mataas yung insulin mo, tapos dietary fats mo mataas, adipose yung fatty acids, and then meron kang fructose. Kasi may GLUT2, makapasok siya, it will cause a lot of damage to your liver, causing fibrosis, eventually cirrhosis. Okay? Pero lahat ng yan, kayang gawin ni alcohol. Lahat ng yan, kaya niyang gawin. Okay? Paano mo ma-differentiate kung yung liver damage is from yung insulin fat, adipose tissue, fructose, versus galing sa alak? You should get the liver enzymes, AST and ALT. Pag
Doc,
yes?
you got cut off for a while po.
Okay. Okay na?
Okay na po.
Okay. So, ano yung last part? Okay. So, ito lang natin. So, wala nang mas damaging sa liver than the alcohol. Okay, paano mo i-differentiate yung alcoholic liver disease versus galing sa diet? You should get liver enzymes, okay, AST, ALT. Pag mas mataas yung AST mo sa ALT mo, 2:1, you can diagnose it as alcoholic liver disease. Okay, but usually it's a form of combination. Bakit? Kasi ano ba yung masarap pulutan and i-chaser sa alak? Usually mga high fructose containing products, snacks, diba? Ano pa masarap pulutan? Yung mga mataas sa saturated fat like lechon and all that. Okay? So usually combo sila. Okay? And speaking of that, mga sakit niya, hindi lang liver disease ang kaya nilang gawin. Okay? Mga high-fat foods na yan. Okay? They can also affect your heart via your coronary arteries. Sabi natin, LDL, pag nasobrahan, it's bad because it likes to go to your arteries. Pinaka-favorite ng puntahan, coronary arteries. So it will occlude your coronary arteries, impeding blood flow to your heart, myocardium. Nagkakaroon ka ng coronary artery disease. Okay? A process called atherosclerosis. Let's discuss that more in more detail. Okay? Very important to. Dahil cardio module kayo, it's a disservice kung hindi ko i-discuss yung atherosclerosis. So atherosclerosis, nag-start yan through an endothelial damage. Okay? So endothelial damage, marami pinanggagalingan yan. Okay? Basically, if you're old fat smoker, may cardiovascular disease ka, diabetic ka, hypertensive ka, you can expect na may endothelial damage yan. Old kasi wear and tear, and then fat, maraming cholesterol, smoker, yung mga carcinogens sa smoke will cause endothelial damage, yung usok, and then all that. DM, yung mga sugar, okay, mag-cause ng damage yan. Hypertension, shear stress, na mataas yung pressure, mag-cause ng endothelial damage. Okay? And that's where it all starts. Pag na-damage yung endothelium mo, in your blood vessel, yung LDL mo, opportunista, papasok siya sa loob. Kasi maglalabas siya ng cholesterol sa intima. Okay, yung blood vessels mo pala may 3 layers, intima, media, and adventitia. Yung pinaka-inner layer, dun nagde-deposit si LDL ng cholesterol. And then inside the blood vessel yan, maraming oxygen, ma-oxidize yan. So it will be eaten by macrophages. Okay? Okay? And then pag sobrang dami na nakain ni macrophage, magiging foam cell na siya. And then pag foam cell na siya, marami na siyang superpowers, it can recruit smooth muscle cells into sa taas, forming a fibrous cap. And then, dahil hindi naman dapat wala dyan si foam cell, yung mga white blood cells mo will make it undergo necrosis. Pero buti na lang, may fibrous cap that covers it. Okay? This whole process, yung plaque na yan, it's what you collectively call an atheroma. Okay? So, okay. So, may problema dyan. Kasi, kahit na may fibrous cap yan, very, very fragile yung neck niya. It's prone to damage, yung neck ng cap, okay, as you can see in the illustration here. So, endothelial damage sa neck, very prone. Pag na-damage yung neck ng fibrous cap, may expose yung necrotic core sa inside. So, platelets should come in. They will form a thrombus. And usually, yung thrombus na yan na yung mismong bumabara, not the plaque itself. Okay? Causing MI or heart attack. Okay? So, and collectively, yung syndrome na yan, it's called acute coronary syndrome. Okay? Paano nag-represent yung mga pasyente na may acute coronary syndrome? Usually, they have a typical chest pain or angina. Ano yung characteristic niya? Kailangan lahat present. Retrosternal, nag-graduate sa arm, greater than 15 minutes in duration, provoked by exertion, relieved by rest and nitrates and all that. Okay? Pag yung patient mo presented na ganyan, kailangan mo rule out yung ACS. Paano mo rule out yung ACS? You get ECG. Pag may ST elevation, you can diagnose STEMI. Okay? Tapos on top of ECG, you have to get cardiac biomarkers like TROP-I. Pag negative yung TROP-I findings, unstable angina diagnosis. Pag positive, end-STEMI diagnosis. Okay? So pag STEMI, or ACS, pag nag-positive yung any of that, kailangan mo ibigay aspirin and clopidogrel. Bakit? Kasi alam mo na nga, na-thrombus yung problem. So, kailangan mo ng mga anti-thrombogenic. Okay? Aspirin will deactivate your platelets, so does will clopidogrel. Para wala nang further blockage na mangyari. Yun yung pinaka-important na kailangan mo bigay in a patient with ACS. Meron pang iba, pero taka na yun. Friendly, cardio fellow, and residents na yung bahala doon. Okay? Pag STEMI pala, kailangan diretso siya sa cath lab. Okay? So, pag STEMI, diretso cath lab, pero bigay mo na yung dual antiplatelet therapy. Okay? Okay, so kung na-stabilize mo na yung patient na yun, kailangan mo naman to manage the risk factors. So yung vulnerable plaque na sumasabog sa neck, kailangan mo gawing stable plaque. Okay? Paano mo isa-stabilize yung plaque? You have to decrease the LDL, bad cholesterol, you have to increase the HDL, and all that. Okay, paano mo gagawin yan? Pinag-usapan natin kanina. Through diet, unsaturated fats, kaya mo yung gawin, okay? And exercise. Okay? Pero kung hindi gumana yun, you have to give drugs. And ang pinaka-nagsastabilize ng plaque na drugs is your statins. It's the king of all anti-lipidemics. Paano nag-work yung statins? It inhibits HMG-CoA reductase. Yung HMG-CoA hindi nagiging mevalonate, hindi nagiging cholesterol. So, you stabilize the plaque through inhibiting synthesis. Okay? And you lower the cholesterol. Okay? Pwede mo rin i-block yung absorption. May mga drugs for that, ezetimibe, bulpatimide. So, yan. Yung block absorption, you can also block storage. Fibrates, niacin. Okay? So niacin, it's a nutrient, but it's also used as an anti-lipidemic. Isa sa mga advantages niya, it increases HDL. Okay? But, pwede mo nakalimutan lahat yan. Huwag mo nakalimutan si statin because it's the king of all the anti-lipidemics. King siya in a sense na meron siyang sariling guideline. Okay? So yung guideline na to, basically, sinasabi, pagka present yung mga nasa red box na yan, basically, paano ko naalala yan? Basically, pag yung pasyente mo, old fat smoker, may cardiovascular disease, hypertensive, and diabetic, kailangan mo siya bigyan ng statin. For what? Plaque stabilization. Kasi old fat smoker, CVD, DM, and hypertensive, you can suspect na may atherosclerosis yan. Unstable yung plaque nila. So you have to stabilize the plaque. Pag borderline yung patient mo, or motivated siya, gusto niya mag-try ng lifestyle changes muna, pwede. So diet and lifestyle, that's where we come in. So ang una ko sasabihin sa patient ko na yan, na motivated, sabihin ko, sir, you have to increase your dietary fiber. Why? Because may two kinds of dietary fiber. May soluble fiber, may insoluble fiber. Yung soluble fiber, like oats, okay, meron niyang beta-glucan. Okay? Yung beta-glucan, pag kinain mo yan, mag-mix siya sa water, magiging gel-like siya sa GI tract mo. So yung gel-like yan sa GI tract mo, it can bind to cholesterol para hindi ma-absorb yung cholesterol. Tatayo mo siya, making your stool more soft and good consistency. Okay? At the same time, meron ka pang insoluble fiber that will aid in your digestion. And then both of them, they can also regulate blood glucose and all that. For goods, okay pa yung stool consistency mo. So, maganda yan sa mga cardiac patients na nagsususpect ng ACS because pag okay yung stool consistency nila, hindi sila umiire, less training. Okay, yung iba, pag ire, doon sila na heart attack. Okay? So, very important dietary fiber for cardiovascular disease patients. Ano mga example? For soluble fibers, mga chia seeds, sweet potatoes, flax seeds, broccoli, and oats. Soluble fibers yan. Mga insoluble, you can add to your stool bulk, bran, cereals, whole grains, corn, green beans, and fruits to my skin. Okay? Pero on top of dietary fibers, okay, sasabihin ko rin sa patient ko na, sir, gusto ko yung diet mo, hindi lang dietary fiber yung affect natin. Gusto ko holistic diet tayo. Gusto ko meron kang balance, variety, and modulation. So, ito yung sa'yo, Mediterranean diet ka na lang. Kasi may sakit ka sa puso, pag Mediterranean diet ka, 100% full conviction. Bakit? Kasi kaya ko explain sa kanya bakit maganda sa kanya yung Mediterranean diet dahil nag-attend ako ng lecture na to, integrated lecture. So let's start with the base. Okay? Pinakakailangan niyang gawin, starting from the base. Daily physical activity, eating with family. Bakit? Kasi exercise can promote energy balance, it will lower your insulin, it will promote Lipogenesis, Glycogenolysis, and increase your HDL. Hindi ka nataba. Next, ba't kailangan ng whole grains, fruits, vegetables? Kasi mataas sa fiber, soluble fiber, insoluble fiber. Soluble fiber, pag kinain mo, gel-like, magbabayin sa cholesterol, bababa yung cholesterol, good stool consistency, less training. Mas hindi ka atakin sa puso kasi iirit ka ng matindi. Okay? Bakit kailangan ng olive oil, fish, and seafood? Kasi mataas sa polyunsaturated fatty acids, omega-3, anti-inflammatory, decreases your bad cholesterol, increases your good cholesterol. And olive oil, monounsaturated fatty acid, decreases your bad cholesterol, increases your good cholesterol. Okay? Yung mga nasa taas, yung mga next, ba't kailangan niyang iwasan? Okay? Kaya nasa tuktok ng pyramid, kailangan iwasan. Bakit? Kasi mataas yan sa mga saturated fats. Animal fat, diba? Daily mataas sa saturated fats. Mataas din sa trans fat, yung mga sweets, yung mga snacks. Mataas sa fructose corn syrup. Alam natin, hindi okay yan. Kaya kailangan iwasan niya yan. Okay? On top of that, iwas siya sa alak, saka huwag siya mag-OC. Bakit? Kasi ipopromote niya ng alak, promotes fat storage, lipogenesis. Smoking promotes endothelial damage, liver toxicity, and all that. Okay? So we've come full circle, okay? So that's the end of my presentation. So I conclude na congratulations guys, you went full circle. We discussed this issue, micro to macro tayo. First we discussed obesity as a public health concern, and then we took a look at the structure of the fats, what it looks like molecular, atomic, microscope level, and then in real life, some examples. And then we took a look at the function, how it's synthesized, transported, stored, and metabolized, and then correlated clinically, basic sciences, clinicals, correlated, why, when, how we treat or intervene. And then at the end, we went, we applied dietary advice to the Mediterranean diet. So I hope that's helpful for you. I hope it made you more clear sa mga concepts ito. And yeah, thank you for listening. So connect with me on social media if you can. Thank you.